Let's move on. So let's assume that we have a young patient who needs therapy, Jatin. You're at MD Anderson. Well, how do you treat a young patient with newly diagnosed myeloma?
So I think for our newly diagnosed myeloma patients, especially our young patients, I think we strongly will consider these patients to be transplant eligible and consider for their transplant after induction therapy. So the question really comes up to is what is their induction therapy that we'll use for a newly diagnosed patient that walks into clinic today? And I think historically now we've seen that the discussion's always been around 2 drugs versus 3 drugs, and in which 3 drug being bortezomib plus an alkylating therapy or bortezomib plus an IMiD. And I think we have a lot of clarity in the last 12 to 18 months around that. So now what we've seen consistently is that 3 drugs is better than 2 drugs. And so we've seen this from the SWOG study where we looked at lenalidomide bortezomib dex versus Lendex. We've seen this in the relapse refractory setting from Aspire and Tourmaline, that the combination of 3 drugs is superior to 2 drugs. So I think that.
Tell me about the SWOG study since you brought this up. This is bortezomib Lendex versus Lendex alone. And what did that teach us?
So it really taught us that I think that with that 3-drug combination, we have higher response rates in these patients. We have a better progression-free survival. But importantly, we also have an important improvements in overall survival as well, which I thought was difficult to prove in the frontline therapy. And I think that was very important. We saw an improvement in overall survival with 3 drugs. But what that really highlights is one thing that we forget, which is use your best therapies up front. And so that's an important oncologic principle, to use your best therapies. And I think this really validates that. And if we can stick with that, that will help us understand how to use all of our therapies as we move forward.
It always astonishes me that that's such a hard message to get across. And
exactly.
Does anybody disagree that we should use all our best therapies up front, that we should maybe sequence and save things for later? Is anybody in that camp?
No, I agree. We should use the best drugs up front. And also I would like to add to that, I think it's equally important to monitor the depth of the response. I think that's equally important. Not only give the drug, also to monitor and see how well it really works and see if there is need to improve and change the therapy.
Is bortezomib dexamethasone alone an adequate therapy, or would you consider that inadequate therapy, Bill?
Well, I would echo what's been said before, that I think there's clear data that 3 drugs are superior to 2 drugs. And so I think in any patient with symptomatic myeloma, and I would include even non-transplant candidates if they're fit, I think a 3-drug combination is currently the standard of care for these patients. You want a high quality response, and you want it to occur within a few cycles of therapy.
So within the 3-drug combinations, we get quite a lot of choices these days. And Rafael, you were one of the early founders of the cyclophosphamide-based combination we call CyBorD. Is that something we should still be using, or do you think there are better choices now?
Well, there was a trial presented at the ASH meeting with Philip Moreau, of course, presented VTD versus VCD. So let's say IMiD, dexamethasone versus cyclophosphamide combinations. I think in general we're learning that IMiD-based combinations are better and triplets. The only comment, and this is more for if there's anyone from the international audience, I think a cyclophosphamide combination is still highly effective. In that particular study, there were only 2 days of overlap of the bortezomib with the cyclophosphamide, which is not really how we practice the CyBorD. But I'll just second what everyone has been saying. I think the triplet combinations are really the standard. And in fact, the numbers don't matter as much as the components, because very quickly we're going to be facing monoclonals plus, and we're going to talk more about that. But I think everything we're discussing today is only temporary, given what's being presented at the ASH meeting.
I was saying to Bill earlier that one of the issues with the cyclophosphamide combination is we've watered it down so much by going from twice-weekly bortezomib to once-weekly, high-dose dex to low-dose dex, and it's not quite what we originally published. So, what about ixazomib? This is a new oral proteasome inhibitor that's been combined in the frontline setting. What do you think about that as a choice?
Well, it's not yet approved for the upfront indication, obviously. I think the data looks to me very attractive for the relapse data. We have heard at meetings and has been published also this year. I think it looks like equivalent of Velcade, but you have the convenience factor on oral therapy. I personally do think that for a younger patient, my preference would be to probably give Kyprolis because I think there is more power in that drug. But I think there could be very many instances where you still could use the oral drug just for the convenience. So I think both those drugs are very good options, and different patients would have access to these.